بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين دكتور سعد والأخوة أعضاء اللجنة التنظيمية والعلمية، شكرا لكم وعلى بركة الله. وخير ما نبدأ به حفلنا الكريم بهذا اليوم آيات من الذكر الحكيم. بسم الله.
بسم الله الرحمن الرحيم. الرحمن علم القرآن خلق الإنسان علمه البيان. الشمس والقمر بحسبان والنجم والشجر يسجدان والسماء رفعها ووضع الميزان ألا تطغوا في الميزان وأقيموا الوزن بالقسط ولا تخسروا الميزان والأرض وضعها للأنام فيها فاكهة والنخل ذات الأكمام والحب ذو العصف والريحان فبأي آلاء ربكما تكذبان خلق الإنسان من صلصال كالفخار وخلق الجان من مارج من نار فبأي آلاء ربكما تكذبان.
صدق الله العظيم. بسم الله. الإخوة أعضاء اللجنة التنظيمية، الإخوة أعضاء اللجنة العلمية التحكيمية، الإخوة الباحثين، جمهورنا الكريم، أهلا وسهلا بكم. تقد يمكن الفرصة طيبة دكتور سعد نبدأ إذا تكرمت. بسم الله الرحمن الرحيم.
طيب،
على بركة الله.
بسم الله. الحمد لله والصلاة والسلام على رسول الله. أول شيء أنا صباحكم الله بالخير وأرحب فيكم جميعا in our research day for emergency medicine hosted by Dr. Sima Al-Habib Medical Group through the Saudi Council regarding this event. بصراحة يعني احنا we feel so proud to see our residents, our heroes. They are actually doing a lot of projects, very interesting projects in research. أنا شخصياً دائماً أقول إنه I feel proud إنه أنا أحد مخرجات الإمرجنسي ميديسن من هالبرنامج، وفخور جداً إنه نشوف شبابنا وبناتنا they are continuing in this direction about the research. هالتجمع اليوم بحضوركم صراحة تجمع مبارك، يعني أسماء معروفة، seniors, leaders في مجال emergency على مستوى البلد. As panelists, around 7-8 projects, variety of interesting topics. We feel so proud by these projects. وسعيد جدا انه نكون معاكم اليوم. نتشرف جدا فعلا بوجود هالاسماء النيره، ووجودكم صراحه اضفى الشيء الكبير على ريسيرش داي. شاكر ومقدر للدكتور توفيق على كل الافورتس وفريق العمل معه للترتيب حق الايفنتس. الاستاذه رسميه ايضا للتنسيق من داخل مجموعه الحبيب. وشاكر ومقدر حضوركم جميعا، اتمنى لكم التوفيق وبسم الله نبدا.
باسم مجموعة الدكتور سليمان الحبيب، أهلا وسهلا بكم باسم منظم الحفل وراعي الحفل الكريم الدكتور سعد العسيري. أهلا بالجميع. وننتقل الآن إلى الإخوة أعضاء اللجنة التنظيمية، وعلى رأسهم الدكتور ماجد السلام والدكتور عاصم السعيد. دكتور ماجد، الميكروفون معك، تفضل.
بسم الله. السلام عليكم جميعا. أحب أرحب بالجميع وأشكر الدكتور سعد عسيري والدكتور توفيق على حسن التنظيم وعلى الدعوة الكريمة. وبسم الله نبدأ. أتوقع أنه إن جميعا إن شاء الله متشوقين نسمع على وش راح يقدمون أبنائنا.
الله يبارك فيك.
فأعتقد أول من راح يقدم معانا الدكتور عبد الملك الدبيان.
نعم.
إذا هو جاهز للتقديم. طبعا موضوع عنوان البحث Attitude of Emergency Medicine Residents in Saudi Arabia towards Simulation-Based Education. It's an education-based project. فعلى بركة الله.
السلام عليكم، صباح الخير.
سلام دكتور عبد الملك، الله يحييك، تفضل.
حياك الله، الصوت واضح؟
نعم الله يحييك.
صبحكم الله بالخير جميعا. بس اسوي دكتور شير عشان البرزنتيشن.
لو سمحت ايوه دكتور عبد الملك.
سام؟
ايوه خلاص عبد الملك تفضل. Just open your slide إذا تفضلت عنده.
طيب بسم الله الرحمن الرحيم. صبحكم الله بالخير جميعا. I am Abdul Tubayan, an emergency medicine resident R4 from National Guard Hospital. Today, inshallah, I'm going to speak about our research, which is educational study, which is attitude of emergency medicine resident in Saudi Arabia towards simulation-based education. Our objectives of the study is to identify the emergency medicine resident satisfaction with simulation-based education used in their training in Saudi Arabia hospitals, to assess the emergency medicine attitude in newly implemented simulation-based education techniques and their effectiveness, to identify the challenges faced for emergency resident during simulation-based education sessions. The methodology, it's a cross-sectional study designed with a qualitative approach. The qualitative data include information gathered from the questionnaire, which was distributed through email to the resident, which was collected expressed in numerical fashion. The study is targeting emergency medicine resident currently practicing in Saudi Arabia. So there was a 124 participants participated in our study. The first table find that out of 124 participants, 118, which is 95%, find that the simulation is a useful learning tool. 88% find that simulation made the subjects more interesting. 82% of the applicants find that the simulation helped them retain their knowledge. 90% of them find the simulation helped them to apply what was learned in classes. 83% find the simulation develop their clinical decision-making ability. 83% find the simulation helped them to gain more communication skills. 87% of them find the simulation should think that the simulation should include it in their courses in more frequent matter. 81% find the simulation provide them semi-realistic realistic experience. 66% feel comfortable while they are practicing on the simulation. 88% of the participants find that they would like to have more training with simulation. 79% find the simulation teaching help them in sharpening their clinical reasoning skills. 72% of them find the simulation develop their clinical decision-making ability. 69% find the simulation help them to early recognize the patient condition. 92% find it was a valuable learning experience, and 78% find the simulation tested their clinical abilities. The second table, which is showing the challenges faced to the resident, 59% of the residents think the skills sessions had adequate facilities. So 55% of the residents think that the simulation session has an appropriate time. 83% find the facilitator provide constructive criticism. Briefing. The facilitator summarized the important points into the debriefing, and got the chance to reflect on their experience of the debriefing. 80% find the facilitator provided feedback on time, and 81% find the feedback was constructive, that improved in their learning. So out of 124 participants, 73 were senior resident and 51 was junior. 118 find the simulation as a useful learning tool. 110 agree that the simulation that the subject is more interesting, help them to retain the knowledge. 90% agree the practical simulation helped them to apply what was learned. 83% see that developed their clinical decision ability. 83 find their communication skills were improved. 66% feel that they are comfortable when they are practicing simulation. 88% want to have more clinical training sessions, simulation sessions, and 92% agree that's a valuable learning experience. Many challenges were faced during the sessions. The most important are shortage of facilities, short period of time of the session, which was generally 4-hour sessions, and the briefing was not done in 80% of the time. So in conclusion, the simulation is an important practical learning tool that makes the subject more interesting, improve the resident clinical judgment and knowledge, help them to apply what was learned in classes, improve their communication skills, and it was a valuable learning experience for most of the residents despite the few challenges. So we strongly believe that more simulation sessions should be introduced to the residency teaching program and in more frequent manners, as it will improve their clinical sense and judgment. And that's it. Thank you so much.
طيب شكرا يا دكتور عبد الملك. نسمع من البانلست. الله يعينك، معك 2 بروجرام دايركتورز هم اللي بيقيمونك، دكتور علي الخليف والدكتورة سميلة الصومالي. نبدأ بالدكتور علي، إذا عندك remarks or discussion.
السلام عليكم جميعا.
السلام.
يعطيك الله العافية أبو عمار. وجست clarification، ممكن في الميثود ذكرت it was cross-sectional وذكرت إن it was qualitative.
Yes, cross-sectional study, which was a questionnaire was distributed to the resident. We included all the sample available. So we got 124 participants, in which sample size was not calculated because all the resident was included.
ممتاز. طبعا very nice idea، يعني بالعكس people might use it to يعني present it to enhance more simulation integration in our curriculum يعني different centers. فالله يعطيك العافية. يعني البروجكت is useful. ممكن فقط النقطة أن هذه الستارت بوينت حق الأوتكمز، يعني واحدة منها اللي هي satisfaction. لو استطعنا أو استطعت يعني حتى لو كان next project سواء أنت أو أي أحد من الزملاء أن to move to more hierarchy، يسموها Kirkpatrick hierarchy. أول شيء satisfaction، يعني الناس مبسوطة، الناس everybody is willing to use this tool، بس does it impact the learning, the knowledge, the skills أو attitude؟ طبعاً في future ممكن حتى تنتقل لمرحلة أعلى، هذه probably will take years. Does it change the patient outcome أو بالأحرى الculture، بعدين على مستوى السيستم. فهذا keep in mind إن this is the start point which is great، الله يجزاك خير عليها. بس اللهم if you can approve إن it does improve the performance سواء في simulated environment، والأفضل طبعاً in real environment will be really very good.
سميرة.
السلام عليكم.
السلام.
الله يعطيك العافية يا عبد الملك. Thank you very much for the presentation. I just have يعني a question and I have a comment. So my question to you, you mentioned that you used in the methodology. I would have liked if you explained more صراحة في methodology part. You sent questionnaires to the residents, and how much was the response rate that you received?
Okay.
And what method did you use to distribute the questionnaire?
Okay, the questionnaire was يعني كان link distributed to the resident through email. We sent the link multiple times. The response rate was initially good, but then we needed more number, and the questionnaire was sent many times. The second or third time which was sent, it was not optimal, the response rate, but it was distributed electronic questionnaire which was distributed through the email.
Okay, and the other thing, the participant, did you include residents only in Riyadh or from all over the kingdom?
We sent all over the kingdom. Most of the participants were from Riyadh, but our inclusion was any emergency medicine resident have training program in Saudi Arabia, not exclusively to Riyadh.
Okay, thank you. So my comment, honestly, the idea, it's a great idea, and I would second what Dr. Ali mentioned, that we can come up with more ideas that makes the research about the satisfaction and what is the real impact of simulation on training. And I was really surprised to see, if we can go back to the item challenges slide, please.
This one?
Yes. No, the next one, please. It has a table, the one with the table.
There are two tables, this one, this one.
No, so the first one, sorry. Yes, so they have found that 59% of the patients, of the residents, that the skill session had adequate facilities, and 55% the skill session had appropriate time. So I was wondering, do you have any comments about especially the time of the session? Why they thought it's not appropriate? يعني almost half.
Almost half. ما كان في commenting, but most of them think the simulation session mostly is 4 hours. So we got comments. The questionnaire itself has no comment space, but most of them agree that it was not. They want to have more sessions and more time, more than 4 hours.
So they need more. They need more time.
More sessions and more time for each session.
Okay, so that's all what I have. شكرا يا عبد الملك، يعطيك ألف عافية.
شكرا يا دكتورة سميرة. عندنا سؤال من الدكتور محمود، وعندنا الدكتور زهير عسيري أيضا رافع يده. سؤال الدكتور محمود يقول هل هم كلهم من سنتر واحد؟ Do we know the distribution of these residents across the centers or the cities? يعني هل ممكن إنه كل اللي جاوبوا هم ناس جاي من المدينة ومن الجامعي لأن عندهم simulation center؟
Most of the participants were from Riyadh, from different hospitals, not exclusively from الجامعي ولا الحرس ولا المدينة. في participant من الشميسي، في من الحرس، في من يعني different hospitals.
هي تسوى إنه نحط جدول للديموغرافيكس، كم ميل فيميل، كم واحد من السنترز المشكلة، أساس الناس تعرف إيش طبيعة البوبيليشن هذه. تفضل دكتور زهير.
السلام عليكم وأسعد الله صباحكم جميعا بكل خير. I love this type of presentations activity. شكرا جزيلا دكتور سعد ودكتور توفيق for inviting us in this very nice gathering. My question للباحث, the questionnaire, was it validated questionnaire?
It was validated questionnaire, yes. It was used for a different study outside the kingdom. It was validated questionnaire.
With the same language or different language?
لا, different. It was in English.
يعني validated لكن done in different language or in the same language, in English language?
No, the validated questionnaire was in English, a different language.
كيف different language؟ يعني أنت عملته بالإنجليش language صح؟
Yes, yes.
It has been done somewhere else in the same language with English صح؟
Yes.
Okay, so the same language. طيب شكرا لك.
طيب ممكن we're almost ready to close، بس عندي يعني remark صغيرة على أساس تساعدك في الببليكيشن هذه، لأنه أملنا إن شاء الله هذول كلها تصير peer reviewed publications. تسوى في الدسكشن إنك تسوي benchmark مع other studies. إيش حصلوا في الدنمارك، إيش حصلوا في أمريكا، هل إحنا الريسبونس ريت حقنا او الساتسفاكشن حقنا اقل او اكثر من الريزيدنتس في السنترز الاخرى. وبس ما عدا ذلك الله يحفظك ان شاء الله ويوفقك في اكمال هذا المشروع.
الله
توفيق الملك.
شكرا عبد الملك، شكرا بارك الله فيك.
يعطيكم العافيه.
We'll go to the next speaker. The next speaker is دكتورة رؤى عامر and along with دكتورة هدى تركستاني.
اعتقد مريم عفوا.
مريم ايوه مريم نعرف. اوكي.
انا خطأ مطبعي معلش.
So their topic will be about triage. It's utilization of routine administrative data at emergency department triage to predict hospital admission. تفضلي دكتورة رؤى.
السلام عليكم. ان شاء الله انا مريم تركستاني، انا حقدم البرزنتيشن.
على فكرة الدكتورة رؤى she's in sick leave and that's why she shared the presentation مع مريم تركستاني. تفضلي يا مريم.
كذا واضح في البرزنتيشن؟
ايوه تفضلي الله يحييك.
Good morning, everyone. I'm Mariam Turkestani, R2 at King Abdulaziz Medical City in Riyadh. I'll be presenting utilizing of routine administrative data at emergency department triage to predict hospital admission. The co-authors are Ru'a Amir, Lujain Malaka, and Dr. Samir Somali from King Abdulaziz Medical City, Riyadh. In the beginning, it is known that many patients present to the emergency department daily with different complaints. ED crowding inversely affects the quality of care and outcome, as well as it increases the risk of adverse event, morbidity, and mortality in relation to increased length of stay in emergency department. As the study has shown that association between length of stay in emergency department and poor outcome on individual patients. Well, our aim is to establish a model to predict the likelihood for hospital admission using routinely gathered information from the registration. Well, it will help to trigger immediate initiation of the admission process by notifying the emergency department clinician and bed management, which in turn will decrease the emergency department crowding. This is a retrospective electronic chart review study using the routinely collected data from the triage to predict hospital admission. The study was approved by King Abdullah International Medical Research Center and was conducted in the emergency department of King Abdullah Medical City in Riyadh. The study included all adult patients visited the emergency department of King Abdulaziz Medical City in Riyadh from January 2018 to December 2019 and found to be 146,000 patients with a calculated sample size of 1,060 visits with confidence interval of 95%. Our exclusion criteria were any patient under 14 years old, obsconded, triaged away, did on arrival to the emergency department, and admitted directly to the general ward or intensive care unit. The variables were collected are the Canadian triage and acuity scale, age, gender, mode of arrival, comorbidities, and previous hospital admission with the same complaint. We applied a stepwise logistic regression to assess the effect of the model predictor on inpatient admission, where the sample size is 1,060 visits, randomly split in two sets. The deviation set, which is 60% used to develop the model, and 40% used to validate the developed model. This table shows the admission rate by patient and the study characteristic. However, in general, among all the 1,060 visits, 20% resulted in admission. If you follow me here, actually in the table, you can see the maximum age-specific admission, 40% among the patient aged from 75 to 84 years, and 39% among patients who aged 65 to 74 years. Also, we found that is highly significant admission rate among male patients. I'm not sure if you can see the numbers because the Zoom videos, but however, it's a male patient in compared to female patient. for non-Saudi in compared to Saudi patient. Also for those patients who came to the emergency with an ambulance in compared to those patients who can walk in, and those patients who were triaged as CTAS 1 and 2 in compared to those patients who were triaged as CTAS 3 and 4. Also for those patients who have a previous hospital admission or emergency department visit in the past 1 week, 3 months, and 6 months, in compared to those who do not have any previous hospital admission or emergency department visits. And also for those patients who have comorbid as hypertension, diabetic, heart failure, coronary obstructive lung disease, in compared to those patients who do not have any comorbids. Well, this table summarizes some of the chief complaints encountered during the study and their admission percentage. As you can see, the most two important we have are the abdomen pain and the loss or decreased level of consciousness, as we will discuss now. This is the hospital admission model estimation. Well, the logistic regression analysis for hospital admission showed a progressively rise in admission for CTAS 3 in compared to CTAS 2, with an odd ratio of 0.04 for CTAS 3 and 0.002 for CTAS 2. Also, the admission risk for patients with an abdomen pain were higher than the patient who came with loss or decreased level of consciousness, with odd ratio of 0.34 for the abdomen pain and 0.24 for the loss or decreased level of consciousness. As you can see here, this is the ROC curve, and it should be between 0.5 and 1 to predict an accuracy of any model. Here we have it at approximately 0.9, which is more than 0.5 and near 1, which indicate a high model acceptability. For furthermore elaboration, our study included different patient characteristics, as we discussed before in the results section, without focusing on a specific age group. However, our finding of higher admission rate in elderly patients was consistent with other studies who specify a specific patient population. For example, the identification senior risk tool and calculation of the elderly admission risk in the emergency department. Very few studies focused on developing a model based on the CTAS and return visit for procedure for admission possibility. However, very few studies included the presenting complaint as a part of the admission for model development, as in our study. Like any other study, our study has its own limitation. The main limitation was the number of encounters to develop and validate the model. And the discrimination power of this model is low because of the limited predictor and sample size. Also, the proportion of CTAS 1 cases was low due to high mortality rate, as death in the department was one of our exclusion criteria. Also, there was other limitation, as many different institutions use different triaging system. The potential selection bias given in our study, as the venue is the tertiary and military hospital. Also, we think that including vital sign in the presentation could improve the model performance even more. To conclude, the model has an acceptable accuracy. This predictive model will help triage nurse identify patients in need for admission early in the emergency department and expedite the admission process. Finally, implementation of such a model in the electronic chart medical system might help to decrease the length of stay, which in turn will decrease the emergency crowding and increase the patient care and quality. This is our main references. Thank you everyone for listening. I really appreciate this opportunity to present in such a day. I'd be happy to answer any question.
شكرا يا مريم. I think we can move on to the discussion panelist. الأول الدكتور بدر الداود. تفضل الدكتور بدر.
يعطيكم العافية. أسعد الله صباحكم جميعا. Well done, دكتورة مريم. It's a very interesting topic that's being addressed many times by emergency departments, and I think that's very interesting to see that from one of the hospitals here in Saudi. I think the question is, I have a few questions or clarification. So how would you explain the category 2 versus category 3? Because you mentioned in the result that the category 2 was less, had less admission compared to category 3. That's one. The second point, can we implement this in the triage in terms of predicting, but can we make it as a protocol to start the admission process or order? And once the admission order is in, do you think that the emergency physician, or that will eliminate the emergency physician role, or do you think that still the emergency physician, they need to get involved in assessing the patients and making the decision? Thank you.
Well, as in regards for your first question, as why CTAS 3 more than CTAS 2, we are thinking that it could be because of the mistriaging, as the nurses who do the triage, it's mainly because of the mistriaging. As in regard for your second question, I think still if the patient needs a resuscitation, patient have to be seen by the emergency department clinician. Any patient have to be seen by emergency department, so to stabilize the patient first, and then if he need admission, he will have a bed already assigned in the department.
Excellent. Another comment, were the triage done by nurses who were their first language was Arabic or English, or they were, excellent in terms of bilingual?
Actually, in our hospital, the nurses do the triage, or sometimes the staff physician. Usually they speak two languages.
Excellent.
But still,
thank you.
this is all, but ما كان including in our study.
Yeah, it's just because some of the nurses, if Arabic is not their first language, sometimes they don't get the full or I would say appropriate triage because of the language barrier. I mean, this is something that we face in some of the hospital here in Saudi, and it's expected if your first language was not Arabic, then there are some gaps that sometimes the nurses, they find difficulty to write them down in terms of the triage assessment. Okay, excellent. يعطيك العافية. شكرا.
Yeah. Thank you.
Dr. Hani Ibrahim, if you have any comment.
Yes, good morning, everyone. Thank you, Dr. Mariam, for this nice project. Definitely, we are in need of such project to solve the overcrowding in the emergency department and to ease the admission process. I have one question regarding the admission rate. If you can go back to the admission rate schedule. You showed us that the admission rate and those who age group, I think 55 to 56 or 64 often, has the lowest rate of admission rate from 55 to 64. Yeah, if you look at this age group, they do have the lowest admission rate. Can you explain this, please?
Well, actually, I have no explanation for this.
أنا أعتقد هنا وقفة جميلة بأنه شوف السينيور فيزيشنز الادميشن ريت حقهم أقل من ريزيدنتس. ريزيدنتس لاقين في الكاتيجوري حق 25-34 بس للناس اللي تحب تتريق على الألدرلي. Probably just a sampling.
Second question, Dr. Mariam, regarding the triage. Some of the hospitals, they do a triage by physicians. Do you think this is going to affect the accuracy of such project? Because we overestimate, and usually physicians, they will do more than the nurses. Nurses, they will do like a quick job, while the physician, sometimes they overestimate. What do you think?
Actually, I totally agree with you. Some physicians, they go with their clinical judgment more than the chief complaint and the vitals and etc. So they sometimes exaggerate. If they fear of some specific complication, they will exaggerate.
And the triage, I think in the Riyadh, I think most of it done by nurses, except a few hospitals. they involve physicians during the triage?
Yes, in our hospital it's done by nurse.
Done by nurse, but I think you have like a physician. They will assess during the triage, so they can change the decision. You know.
Yes, sometimes.
Okay. Okay. Thank you so much.
Thank you.
ممتاز. أنا يمكن بس عندي ملاحظة صغيرة في الموديل اللي بعد، يمكن السلايد اللي بعد هذه اللي فيها الأودز ريشيوز.
هذا.
أيوة. لو تلاحظين الأودز ريشيوز مرة منخفضة في الناس اللي أدميشن ريت حقهم عالي، ومرتفعة في الناس اللي أدميشن ريت حقهم أقل. You're modeling for discharge not admission rate. فيبغى لك بس يبغى لها تعكس اللي سوت الاناليسيس، يبغى لها بس تعكس الادميشن الى 1 بدال 0 so that you get high odds ratio with patients that have very high admission rate. أو نتكلم عن الdischarge, one of the two.
Okay, we will look into it.
في شخص واحد دكتور فهد Samarkandi had سؤال. I think the tool can be enhanced by involving senior physician early on. What do you think about this idea? أساس يقرر الهاي.
I really didn't get the question.
يسأل إنه لو حطينا senior physician early on في triage, would this enhance this tool or not, do you think?
No, I think it's going to be the same. They're mainly going to think about the differential diagnosis, the complication. It will really affect the triaging.
Okay.
So I think more further studies needed for that. I'm not sure.
Okay. شكرا دكتورة مريم. Thank you. Very in-depth study. I guess we can move on to our next project. الموضوع الثاني من الدكتورة لما الفخري. She has an administrative study. The title is Emergency Medicine Personnel's Preparation, Performance, and Perception of Their Night Shifts, Cross-Sectional Study from Saudi Arabia. دكتورة لما موجودة؟
صباح الخير، صوتي واضح؟
النور، تفضلي.
Assalamu alaikum everyone. My name is Lama Al-Fakhri. I'm an R2 emergency resident at KKUH. First of all, I'd like to thank the organizing committee for giving us the chance to present our paper in this year's research day. The title of our research is Emergency Medicine Personnel's Preparation, Performance, and Perception of Their Night Shifts, a cross-sectional study from Saudi Arabia. This is the outline of our presentation. I'll talk about the introduction. I'll go over the objectives of our study, methodology, results, conclusion, and I will touch upon some of the references that I used in this presentation. Now, to start off, as we all know, people are different when it comes to their night shift preparation and their habits. It caught our attention and got us curious to know the emergency department workers' perception towards night shift. And thus, to the best of our knowledge, no study has been conducted in Saudi Arabia that compares emergency medicine physician and nurse preferences regarding these factors, along with the risk of motor vehicle accidents while driving home from shift and insight on the possible physical, mental, and emotional health effects associated with working night shifts. A job at the emergency department usually mandates a switch from day to night unusual basis, which can affect the routine of an emergency department personnel and has a potential risk in developing emotional and physical health issues. As night shift workers, whether working an isolated night shift or career night shift workers, require preparation, acclimation, and physicians and nurses often involve a routine such as sleep during daylight hours, pre or post shift, and the use of sleeping aids and specific meal and beverage choices prior and during their shift. Now, the objectives of our study is to compare night shift habits between emergency medicine personnel, which includes the following three groups: residents, nurses, and attending physicians working in the same emergency department, to determine the differences among the three groups regarding night shift preparation, performance, recovery, and perception of associated emotional and physical health effects. Lastly, to explore the potential adverse effects associated with working the night shift, such as fatigue during or after night shift work and the risk of motor vehicle accidents while driving home. Now, moving on to the methodology, after obtaining an IRB approval, we conducted this study at the emergency department of KSU MC in Riyadh, Saudi Arabia. An online anonymous quantitative survey was administered to nurses, residents, and attending physicians working in the same emergency department. Now, the survey was conducted partially based on a previous published research that was conducted in the United States, with an obtained permission from the author to use his questionnaire as an outline for our study, along with newly introduced survey questions that we thought they could be important for our study. All analyses were performed using SPSS. The inclusion criteria of our study were all nurses, residents, and attending physicians who worked and those who are working night shift in KSU MC emergency department. Exclusion criteria were healthcare providers who do not work in the emergency department and those who covered the daylight shifts. Now, as for the results, the survey response rate was 21% for nurses, 100%
في ناس حوين
فيوم انضربت في المنطقة حقته نزحت.
ميوت all.
منطقة ثانية. صارت الخيمة.
لحظة.
الحالة سيحال إلى قبل يومين ماشي.
دكتور عبد الملك.
بس إنه سبحان الله الصدفة دعوتهم استجيبت. وصارت الناس ترد عليهم.
عفوا.
توفيق can you mute them? تفضلي دكتورة.
معلش تفضلي دكتورة.
Okay. Now for our results, the survey response rate was 21% for nurses, 100% for residents, and 100% for attending physicians, with a total of 123 participants. 33 were nurses, 51 residents, and 39 attending physicians completed the survey. Now, if you can see in table 1, it describes the demographics, compares the pre-night shift routine between the 3 groups, and describes the use of physical and pharmacological sleep aids. There was a significant difference in both age and gender between the 3 groups. Regarding the age, physicians' ages were older than other residents and nurses, whereas more than 90% of nurses were females when compared to the other 2 groups. Now, previous studies have shown that healthcare workers had various pre-night shift habits to cope with the differences experienced during a night shift. Surprisingly, that was not significant in our study, which might be explained by the fact that most of our participants already adapted to working in the emergency department, which requires a change in their sleep pattern and ultimately their lifestyle. Now, nonetheless, in regards to the use of physical sleep aids, there was a significant difference between the 3 groups. It was mostly found within the residents group, as the residents group show no need to use any physical sleep aids. Now, this could be due to the fact that night shift cases are usually overwhelming and hectic, as they include many road traffic accidents, traumas, and colds. Therefore, this might explain why residents fall asleep instantly once they reach their house after such exhausting shifts. On the other hand, there was a significant difference with the preference to use humidifiers as a physical sleep aid, which was noticed in the nurses group. And this can be explained by the higher number of expat nurses who are not used to the dry summer weather in Riyadh, and thus need to rinse it out to ease their sleep. Now, the next set of questions involved which sleep aids had been tried in the past but not routinely used. Antihistamines, benzos, and melatonin were asked about, and not trying any of the aforementioned was significant among the 3 groups. However, over-the-counter and accessible medications were used mostly by residents and nurses, and on the other hand, consultants actually preferred using a drug combination. Now, there were 3 separate studies that investigated the use of melatonin in emergency physicians, and all of which used subjective measures and showed no significant effect. Now, this goes hand in hand with the findings in our study, as we believe that our emergency physicians do not rely on sleep aids due to either personally trying them and finding no significant difference, or because they are up to date with the latest articles in the literature that showed no significant difference between the placebo and melatonin. As well as for emergency department workers face many overdose cases and are aware of the outcome of the addiction. Hence, they choose not to depend on them and frequently use them on a continuous basis. Now, Table 2 describes the preferred meals, beverages consumed before or during night shift, the hours of sleep needed to be functional for a shift, and compares the rate of accidents post-night shift between the three groups. Pre-night shift meal habits were queried about with no significant finding among the three groups in our study. But as a preferred stimulant concerning vigilance, coffee consumption before or during a shift was used extensively by all three groups in our study, which was followed by tea, especially among nurses, which supports previous studies as coffee is widely consumed among shift workers who are working when the rest of the world is resting. Now, there was a significant difference between the groups when asked about the preferred time to wake up before a night shift duty. Residents preferred 3 hours before, while nurses and attending physicians preferred to wake up 2 hours before the night shift. This might be explained by the fact that residents are in a training program in which waking up a couple of hours before a shift can help them accomplish and gives them time to read certain topics to prepare for the shift. Now, moreover, attending physicians have shown to have the most post-night shift accidents in comparison to the other groups. This can be due to the fact that the more responsibilities are on the attending physicians per se, as they are the decision makers in the shift, which leads to overthinking and maybe getting distracted on the way home. Now, the last table in our results was a self-reported Likert scale, which presented the differences among the three groups and their perception towards specific statements that shed light on the effect of night shift work on emotional and physical health. Now, if you can see, residents reported the highest level of satisfaction working night shift and agreed less than the other groups when it came to the association of night shift workers having a shorter lifespan. The possible explanation to this may be that residents express a greater deal of excitement towards night shift work as they are transitioning into well-established positions, while also having free time during the day to complete other responsibilities. Now, the majority of attending physicians agreed with the statements regarding the mental and emotional health effects associated with night shift work. And they strongly agreed that career night shift workers are more likely to depend on drugs and alcohol than did nurses and residents. Now, while some studies have been conducted which highlighted that night shift workers are more likely to depend on smoking, drinking, and eating junk food, none specifically involved the specialty of emergency medicine. Now, along with the dedication and commitment, as well as the considerable number of patients that present with drug and alcohol-related issues, it seems unlikely that a healthcare worker with dependence and addiction issues would be able to go unnoticed or succeed in such an environment. Now, in conclusion, our results show that residents, nurses, and attending physicians shared a lot of common virtues between them. Most differences involved residents who tended not to use any physical sleep aids, consumed coffee as a stimulant, and enjoyed night shift works more. In addition, attending physicians reported higher accident rate post-night shift, agreed most about the increased prevalence of depression and the use of drugs and alcohol in night shift workers. Now, with a growing society and as emergency department visits are increasing over time, it is of grave importance that emergency medicine attending physicians, residents, and nurses maintain their sleep in order to ensure full-rounded care and minimize the challenges of caring for patients during a night shift. These are some of the references that I touched upon in this presentation. You can feel free to scan the barcode for more references. Thank you. Any questions?
شكرا دكتور علماء. I guess we'll give a chance for the discussion panelists to start. الأول الدكتور محمد السلطان. أنت موجود يا أبو عبد الله.
Thank you, Lama, for this presentation and important topic. Just one question for you. Do you think it's one of the limitations of the data you collected, the race differences between the two groups? The nurses, the majority from non-Saudis, which is, we know that the sleep pattern, it's affected by the cultural background, at least what we believe. In Saudi Arabia, due to the weather, due to many other factors, we don't mind to stay late, up to midnight, 1 o'clock, even in our regular life. But we noted in other communities, they eat earlier, they sleep earlier, and they wake up earlier usually. So do you think this is one of the limitations of the results?
Yes, this could be one of the limitations of our results. And in the inclusion criteria, we mainly focused on the nurses or physicians who worked in the nighttime, so night shift workers. So usually night shift workers, they're used to the night shifts, and their sleeping pattern have changed accordingly.
What I meant, Lama, even in the nurses group, I'm sure most of them non-Saudis, the Saudi from the nursing group usually avoiding the night shifts because they have the privilege of smaller number, and they consider it a privilege for the Saudi nurses to work daytime more than night shifts. I noted this in other departments. Maybe in emergency it's applicable, but maybe not.
Yes, I agree.
الدكتور عبد الله السقا.
بسم الله الرحمن الرحيم. أحب أشكر المنظمين المؤتمر العظيم هذا حق الريسيرش. سؤالي أخت لما، في سؤالين. هو الآن بالنسبة للأورز حقت النيرس in general تختلف عن الأورز حقت الريزيدنت وحقت الفيزيشن يعني attending. أنت حطيتيها في الاعتبار إنه هذه one of variability، لأنه تعرف هم in general 12 hour بالنسبة للفيزيشن الريزيدنت والattending physician 8 hours. هذا in general. Did you consider في الاختلاف طبعا بينهم بالhours?
Yes, we did take that into consideration, and at some point during the pandemic, residents and attending physicians both actually tried the 12-hour shifts.
هذا لما كان 12 hour during Corona صح؟
Yes.
طيب, did you compare it with other study, for example, مثلا Canadian, Australian, American result يعني اللي طلعت عندنا compare بالresult اللي برا?
Yes, we did compare some of our results in an article that was published in the United States, in which we used their questionnaire as a base for our research as well.
طيب يعطيك العافية. شكرا لك.
أبو عمر تسمح لي بالمداخلة؟
تفضل.
ما شاء الله تبارك الله. أنا والله really impressed with this study. Thank you, Lama. It's really great job. It's like a fellow level study. You mentioned, ya Lama, and you adopt the questionnaire from American study. Can you please?
Yes.
Which reference is that?
I'm sorry, I couldn't hear the last sentence you said.
What was the study, please?
The study?
From which study, please, in your references? American.
Okay.
So you adopted the whole questionnaire to as if you are validating the other study methodology. صح ولا لا?
Yes, we used their article. That's right.
Yeah.
Not their article, sorry. We used their questionnaire. We used the question. It was partially based on a previous published research, and we took the permission from the author to use his questionnaire and to compare our results to their results. And we added newly introduced survey questions that were deemed important by us. And for the cultural differences, there were a lot of questions that were edited on their survey.
It's very nice just to mention the title of the study for the author. Because I really like your study, your validation. I really like your nova analysis. It's very nice. I am really impressed. شكرا يا لما. Good job.
Thank you.
فيها الدكتور محمود حط سؤال. I noticed that the response rate from nurses was low. Any explanation for that?
I do not have a very clear explanation for that. We tried as much as possible to get responses when we distributed the survey. At the beginning, we had a biostatistician who told us who helped us with the sample size and told us a number that could help us before we start distributing the survey to know whether or not the sample size would be enough, since we're conducting this research only in KSU MC. And according to the biostatistician results, the sample size was around 20 for each arm or 20 for each group would be enough. And therefore, when we started to sorry, it was around 30 if I wasn't mistaken. And therefore, when we started to collect the data, we had around 35 responses from the nurses group. And throughout the analysis, of course, we had to remove some responses due to the exclusion criteria and so on.
طيب شكرا دكتورة لما. أنا يمكن حاجة تقدر تضيفينها كفيوتشر ستاديز، انه هل الانترست حق النيو ريكروتس في الامرجنسي residents او resident nurses that are applying for emergency medicine، هل هم بدأوا يكتشفون انه هذا التخصص مرتبط بالنايت شيفتس، فقاعدين نستجلب الناس اللي اصلا متعودين على السهر؟ يعني في ناس كثيرين اصلا ليليين بطبيعتهم، فلما بدأ يكثر تخرجهم بدأوا ينصبون على التخصص اكثر.
Okay, thank
with that, I think we can move on. شكرا دكتورة لما، الله يكثر خيرك. Our next speaker is دكتور ماجدة عويدة. عودة. اوكي. تفضل.
احنا في الامرجنسي ميديسن بروجرام احنا كمان we welcome all the researchers from the emergency medicine specialty. الدكتورة ماجدة اخصائية سبيشاليست من برايفت هوسبيتال، ما عندها ستراكشر بروجرام لكنها تشجعت عندها كواليتي بروجكت وحبت تشارك معنا. تفضل دكتور ماجدة.
السلام عليكم. Good morning, everyone. First, I am pleasure to thank you for this chance to introduce myself here. My name is Majid Daoude. I am senior pediatric specialist in Dr. Sulaiman Al-Habib Medical Group, Al-Takhassusi Branch, Emergency Department. I would like to share you our audit analysis for lacerations and suturing in ER under supervision of our emergency consultant, Dr. Tawfiq Al-Mizni.
تبدأين العرض، ابدأ العرض بالسلايدات لو سمحت.
It's clear the screen.
ايوه تفضلي.
All we know that with high flu patients in adult and pediatric emergency room, frequent cases and different types of lacerations visits ER daily. According to the international rates, 10 to 13% daily of lacerations visit to the ER. Most of them are simple, but some cases multiple and some cases need complex repair. And we have sometimes family requests for plastic surgery even in simple cases, especially in female. So hesitant sometimes maybe happen in ER when dealing with such cases for some reasons. One of these reasons, most of laceration are considered as occult cases, CTAS 3 or 4. And if doctors are busy with other more acute cases, they will prefer to avoid and calling other surgery specialists for wounds, even in simple cases, to take care of them faster instead of waiting. These lead to overconsultation for other surgery specialists, and this by time lead to decreased skills of ER doctors and increase the problem of avoidance. Our administrations noted this problem and did reaction for the solution. Our vision Vision of our administration and emergency department is handling most laceration by ER doctor to keep flow smoothly. To achieve this vision, regular training had been done last year to increase the awareness of all ER staff about this vision. Through surgery workshops, conscious sedation workshops, clinical simulation, and ground round with cooperation of our surgeon. This aims to serve the patient with better quality, especially that we are private hospital and no surgical training programs here. Through this vision, we succeeded to raise the load rate as before to reach 80% of wound management is done by ER staff now, as we'll see through our quality audit study here. This is our quality audit for wounds management in ER. We collected the data files from the patient through a VIDA system by manual dissection with 1 month, August 2020. Through VIDA system, 6,249 files had been served manually to get 242 wounds cases, which are target of the study, divided into groups. One group or first group for adult, we get 103 cases at 2 to 5% of total visit daily, and 139 pediatric cases at rate of 5 to 20 from total visit daily. Here we can see that the pediatric ER cases is more than adult cases, and sometimes 3 to 5 of the total visit daily. And we divide the item of the study to 4 categories: age of the patient, size of the wounds, kind of the procedures, and who did the procedure. If we look to the adult ER, according to the age groups, we can find here that 75% of the age group is less than 35 years old. And of course, because this is hand-worked age. If we look to the size involved in adult ER, we can see that the extremities, mostly hand, then feet, are the most common size at the percent of 70%, then face at the percent of 13.5. Now we will go to the procedure option versus done by. Our procedures option divided for 4 categories: simple dressing, adhesive, suturing and stapling, and OR. Method of approximation for wounds is decided at first by ER doctors. The doctors will evaluate the wound, then he will decide. We can see here that 50% of the wounds were simple dressing, and simple dressing in our ER is done by nurses after evaluated from the ER doctor. 10% of the wounds adhesive, but this adhesive is done by ER doctor. 33% of the cases need suturing, and only 4% nearly need OR. If we look to this table, we can find that 80% of the total laceration are handled by ER staff and only 20% for other surgery specialists. And this surgery specialist divided between plastic surgery, ortho, and GS. Now, we will speak about the suturing cases and who did the suturing. We have 35 cases in this study. We can see from this table, from these graphs, and from this graph that 57% of the cases which need suturing is also done by the ER doctor. And the other 43% of suturing for other surgery specialists divided between GS, ortho, and plastic. In conclusion, rate of laceration in adult ER up to 5% daily. The most age of wound are less than 35 years old. Extremities, mostly hands and feet, are the most common size, then face. Most laceration had been handled by ER doctor at the rate of 80%. Most cases that need suturing had been done by ER doctor at the rate of 57%. This is our success vision between previous and the present management in ER laceration, and our aim to increase this rate in the future. Now, we will go to the pediatric ER to see the laceration and suturation in them. In pedia, we will see from this table and from these graphs that the age group, the most age group between 2 to 6 years old in 80%. And if we look to the site of the involved site in the children, we can see that the most two size is face and scalp at the percent of 70, especially less than 7 years old. And this is, of course, because the child in this age is more active, but less careful, and this leading to more falls on the head. But with the age, we can see that the upper and lower limbs with the age are more frequent due to using them more than before in activities, and small also child becomes aware, so falls in the head, on the head decrease. Here we can see the distribution map for wounds care in pediatric emergency room. We can see also that nearly 60% of the cases is done by Pedia ER and 40% by the other. And this 40% is divided between 5 surgical specialists. And the most other GS surgical specialist is plastic surgery clinic in 18%. The other for GS, ortho, maxillofacial, and OR, and ENT. Through this table, we can see the suturing and who did the suturing, and also we can see the distribution of the procedure. Distribution of the procedure in total, we have half of the cases for suturing, 22% of the cases for adhesive, and 23 cases for percent for the dressing. And the rate of OR in our ER department is low. From the all cases of the which need the suturing, we can see that 32 of suturing done by ER doctors, and 42 of suturing is done by plastic surgery doctors, and only 26% for other surgical specialists. And we can see from these graphs that nearly all of the dressing and all of adhesive in pediatric ER is done by ER doctors. In conclusion, daily visit of laceration cases to pediatric ER 5 to 20% from total visit. Most of them had been handled by pediatric ER team at rate of 59%. Need of plastic surgery in pediatric ER is more than adult due to the family request mostly, because the most size of wounds children is on the face at rate of 35%, and the most age is less than 7 years old. This leads to the emotional situation at family, even simple wounds. Also, need of hand plastic surgery in children more than adult. Thank you.
ما شاء الله.
شكرا دكتورة ماجدة.
Welcome.
Can we start with the discussion panelist, Dr. Mohammed Sultan?
Thank you, Dr. Majida, for this descriptive information you mentioned. Do you have a chance to, even with maybe it's not the aim of your presentation and project today, to compare the outcome between the specialties dealt with the suture, or no?
In our ER, all doctors doing the suturing and the different levels, residents and the specialists and consultants also sometimes doing that.
If you compare the suture done by emergency or GS or ortho or plastic, do you have a chance to observe the outcome, the different outcome between these 4 groups?
No. Sometimes the cases they make follow up to our ER and sometimes go to the clinics.
Okay, thank you.
Welcome.
Dr. Hani?
Yeah, thank you, Dr. Majida, for this project. Just I have one comment. In your audit, you took only 1 month. I wish if you took more than 1 month duration for this audit, because I think you took only month of August for the audit. The second thing is that did you look at their satisfaction and the family, especially in pediatric, They're
Yes.
looking for a plastic surgeon. They're asking for a plastic surgeon for the suture. What about involving the senior emergency physician, senior specialist, or consultant even for the suture?
Even from beginning, a lot of families come to our ER to ask plastic surgery, and we contact to them, and we offer them to make the suturing in our ER. Some and explain that in simple cases no difference, because we have a lot of studies that refer that in simple cases of wounds that not too much difference between plastic surgery and normal surgery after 3 months for the spares. We explain for them, and some families accept, and some families want plastic surgery.
Yeah. Other point is regarding, this may be not the aim of this project, but maybe we might consider it in the future. If you can compare, before and after conducting.
Yes. This is my other research to continue, and so maybe I will make another research for to see different time, because August, we know that August this summer, and the cases may be less than winter, and I my aim to see before and after for the same cases of the wound.
I mean, after taking the courses, especially for the emergency physician, after taking special courses in suturing, attending the simulation courses.
Yes, we took last year many courses of workshop for suturing and for surgical procedure had been done in our ER, and simulation also ground by surgeon, and also we did conscious sedation to do the even in simple cases of the wound for plastic surgery. Our aim to do them in ER under conscious sedation to decrease the admission to OR under GA.
All right. Thank you so much.
welcome.
دكتور ماجد تسمح لي مداخلة؟
تفضل يا دكتور.
الله يعطيك. دكتورة ماجد شكرا جزيلا for reviewing 6000 charts وعمل جميل رغم انه يعني فترة قصيرة لكن كان في high census and I really your great work. I thank you for your courage to have the courage to come with the panelists to present this project. طبعا the administration object of this one was to improve the suturing in the ER physicians. يعني private hospital فيه avoidance, فيه hesitancy, فيه family pressure, ومع ذلك administration is pushing, encouraging, doing workshop في adult 80% is managed by ER physicians, في pediatric 40%. البيديا is more challenging, يحتاجون conscious sedation sometimes. ما شاء الله يعني بصراحة يعني أنا I really أشكر رئيس القسم بصراحة for his great effort to push forward. يمكن الدكتور سعد العسيري يكون عنده مداخلة إذا تكرم على برانش التخصصي.
يعطيك العافية دكتور توفيق ودكتورة ماجد. Thank you so much. I like your presentation. Excellent initiative. Just we need to ممكن what Dr. Mohammed Sultan mentioned and the team, which is actually some kind of maybe to arrange with our colleagues in the surgery regarding actually the follow-up, because during actually the dressing change and the removal of the suture, somebody gonna to do some kind of audit to know what kind of outcome. Outcome is very important also. So this is very important to improve it for second phase, and hopefully we share this research with other colleagues in the other departments, because they are actually encouraged to do the same. And after the workshops for the suturing done in all the emergency departments there, hopefully everybody gonna to do the same, like what happened in Takhasusi, and hopefully we're gonna to see more improvement in that. But thank you so much.
Welcome.
بس عندي أنا مداخلة أخيرة. Do you think this is a good environment for the residents to actually start? They finish the courses and then they can actually pick up some of the load away from the ER physicians who are busy seeing more acute cases. لأنه حقيقة النسب عندكم عالية مقارنة بالمستشفيات الثانية.
ما فهمت سؤالك ابو عمر.
نسب السوتشرينج
اي
ضمن everyday cases ترى مرتفعه مقارنه بالمستشفيات الثانيه.
التخصصي يشوفون يوميا ما بين 700 الى 850 بيشنت، فاللود اللي هناك عالي. اتوقع يمكن لو شفنا عدد ال او نفس الريسيرش نحمل في الاذر بروجكتس الاذر هوسبيتالز حتكون يمكن الارقام اقل شوي، بس التخصصي دائما ترى ارقامهم عاليه وتوتالي اجري معك.
Yeah, I think it's a ripe. It would be nice to see some results on residents, and if this could be incorporated in the training. طيب شكرا جزيلا، كثر خيركم جميعا. دكتور سعد، توفيق، دكتورة ماجدة. We can move on to the next project.
Thank you very much.
البروجكت الثاني is done by دكتور فيصل الحسين. حقيقة دكتور فيصل الحسين, this may be his 5th project that I've seen him work on since he was a medical student. He seems to be very interested in doing research. His title today is Prediction of Intensive Care Unit Outcome for Critically Ill Patients During COVID-19 Pandemic in Saudi Arabia. تفضل دكتور فيصل.
السلام عليكم، صباح الخير جميعا. صوتي واضح؟
نعم.
طيب شكرا لك دكتور ماجد، شكرا للجنة المنظمة للريسيرش داي. My name is Faisal Hussein. I'm an emergency medicine resident at King Abdulaziz Medical City, National Guard, Riyadh. I'll talk about our research, which is prediction of intensive care unit outcome for critically ill patients during COVID-19 pandemic in Saudi Arabia. So I'll go through this outline, the background, aims, methods, material, results, then with the conclusion and where to go from there. As we know that on the last day of 2019, China reported the detection of pneumonia cases with unknown cases and with unknown cause in Wuhan city, which rapidly transformed into a pandemic caused by a novel virus that led to ARDS that was named as SARS-CoV-2 COVID-19. So the number of cases and deaths due to COVID had dramatically increased worldwide during the first few months in 2020, making this pandemic one of the most serious health emergency in the modern time. It was estimated that approximately 10% to 20%, reaching to 30% of COVID cases progress for critical illness that require intensive care support with conditions of failure of lungs and other organs, leading to higher mortality rate among critically ill patients. This percentage going down with the time since last year, reaching in some areas in the world to 5%, 10%, 2%. So there is inconsistent reports about the critical results. Currently, worldwide, we have almost 100,000 cases in the ICUs due to COVID cases. In addition, as these numbers increase, ICU beds are occupied during the last year, and there was need more for ICU beds. Locally in Saudi Arabia, the Ministry of Health here in Riyadh announced that intensive care unit capacity has been increased by 43%. From reviewing the literature here in Saudi Arabia, we did not find any previous statistical build model to predict the outcome of ICU patients during COVID-19 pandemic. Our aim was to describe the predictor that may influence the length of stay in ICU in Saudi Arabia, predict the outcome of ICU patients during COVID pandemic in Saudi Arabia, and describe the population characteristic of ICU patients and ICU mortality rate for COVID-19 patients and non-COVID-19 patients. As we know that MOH protocols they state that all ICU patients should be screened for COVID during the pandemic, starting with the pandemic. So our method in this study, we utilized a prediction correlation cohort design of retrospective analysis of data collected in IHALA system registry, the Saudi Ministry of Health. The IHALA system is a national patient referral system for all patients in Saudi Arabia under Ministry of Health, and that utilize an electronic case reporting tool managed by the command center of IHALA system. The registry has been designed to capture vital information about every single patient that gets admitted to an ICU at any hospital following Ministry of Health in Saudi Arabia at the beginning of IHALA system. Then it moves to involve or include all the hospitals, academic hospitals, military hospitals in Saudi Arabia, and private hospitals. And from there, we see the daily numbers of COVID cases so in Saudi Arabia. So our study, we include the hospitals in the country under Ministry of Health of that's around 274 hospitals that was at that time ready to be included in the analysis. And we exclude the academic, military, and private hospitals because there were missing data in their registry. The study population were all the patients who admitted in ICU in Saudi Arabia between June 2020 to 15th of October 2020 for adult patients 18 years old and above. As I said, the hospital numbers, we ended up with 6,422 ICU patients during that time. We excluded 18.6% of those patients whether not tested for COVID, awaiting COVID results, or there was significant missing data more than 40%. So the data as COVID case, COVID positive cases were 46.8%, and COVID negative in ICUs in these hospitals were 41.4%. So moving now to the results, we have 4 parts in the results. The population characteristics of all ICU patients in Saudi Arabia. This is the table. The population characteristic of all ICU patients in Saudi Arabia during study period, including the registry, whether they are classified as whether discharged from ICUs alive or deceased from ICU. So we can see here in the ICU, 1,898 patients were elderly patients who are 60 years or more of age. And we can see the mortality rate is about, in this category group, is 45.3% compared to 24.1 with those under 60 years. This includes all patients, COVID positive and COVID negative. And we can see a difference with the p-value. And also in the ICU mortality rate was also found to be significantly different between the males and the females. We see it here, 31.9 among the male and 28% for the female, and was statistically significant. As we said, that negative and positive COVID cases, with the negative cases, COVID cases in the ICUs were almost the death was 20.9% compared to the COVID cases for ICU 41.7%. Moving to the ICU management-based survival of COVID positive and versus COVID and non-COVID-19 positive. This table is for positive COVID-19 patients. Of confirmed positive COVID-19 patients admitted to ICU, 1,180 or 98, 40% were mechanically ventilated with survival rate of 27.5. You can see it here, and mortality rate is 72.5 among the mechanically ventilated patient. This was compared to 1,800, almost 60%, to those not mechanically ventilated with a survival rate of 85.4 and mortality 14.6. So there was a difference between those two categories, who was on mechanical ventilation or not. We can see also other variable here, which non-invasive positive pressure ventilation, 16.7% underwent non-invasive positive pressure ventilation management with survival rate of 67.9 compared to 83.8 who did not receive non-invasive positive pressure ventilation management with a survival rate of 56.6. And this was statistically significant. Just to mention here, non-invasive positive pressure ventilation, if the patient came to ICU, admitted to ICU, he was in non-invasive positive pressure ventilation, he was including in the analysis. And if he was before in the ER, we did not count those patients. If he was intubated in the ER, we consider them as mechanical ventilation directly. In the hemodialysis, we can see it also here. The mortality rate is 73.6 for those who end up with hemodialysis, not originally admitted, and they are known to do hemodialysis, compared to 39% for those did not reach to hemodialysis. We see the other table for non-COVID-19 patients inside the ICU. Those with mechanical ventilation, it's almost similar to the other one, the COVID patients. They end up with death 67%, and those without mechanical ventilation was 14.6. Also, a non-invasive positive pressure ventilation was not statistically significant, almost similar died in the ICU. The hemodialysis, we can see less number among those admitted to ICU for non-COVID reasons. Moving to the third part, the results comparing of average length of stay for various patient groups inside ICU. Higher average length of stay was found to be associated with positive COVID-19 status, older age, being 60 years old or more, being a male patient, being on mechanical ventilation, or undergoing ECMO treatment, and doing dialysis in ICU for the first time in the patient's life. And was not found to be associated with having any of the conditions, comorbidities, chronic cardiovascular or lung or chronic liver, kidney diseases, diabetes or hypertension. Was not significant. Moving to the last part of the results, which is the predictors affecting ICU outcome for comparing positive COVID-19 patients. So these are the tables. This table summarizes the binomial logistic regression model that was built to explain the extent to which of these predictors or these variables to have an influence on ICU outcome for COVID positive patients. So this table only for COVID-19 positive. In ICU outcome probability assessment, the dependent factor has been expressed as the binary variables, whether survive or deceased. Positive outcome was survive, negative was deceased. The model was run. The result of this model showed that, as we see, 5 conditions or variables were associated with variability of ICU outcome: age, being on mechanical ventilation, being on non-invasive positive pressure ventilation, doing hemodialysis in ICU, and having a comorbidity. On the other hand, we can see that gender and length of stay were not found to associate with variation in ICU outcome. So we can see here the odds ratio for comparing COVID patients. The age increase, as the age increased, there was a higher probability of dying in ICU. An odds ratio 1.91. We can also see length of stay as the patient was not associated, as was not significant in this study. Also, we can see here the model showed that there is a higher chance of dying if the patient was being on mechanical ventilation with odds ratio of 9.84, or doing hemodialysis in ICU, an odds ratio 2.2, and having a comorbidity is 1.6, and a higher chance of survival. We can see it here. If the patient was admitted to ICU with non-invasive positive pressure ventilation. So reaching to my conclusion, going back to our aims, this study could help in establishing a model to stratify patients by the risk of death to improve the matching of patients, cohort, whether for planning or clinical trials or etc. It could also support the identification of high-risk subgroup inside ICU in our local community and country. Also, an estimation of ICU length of stay can be made based on existing comorbidities. Also, as we see, the best predictor of ICU mortality is the use of mechanical ventilation, that if the patient come to ICU intubated, and the use of hemodialysis for the first time, and the patient reaching to the area of hemodialysis. Here I reach to end of my presentation. Thank you all for listening. Any questions?
We'll go to the discussion panel. Dr. Badr Dawood.
يعطيك العافية دكتور فيصل. Excellent. Well done. I think it's a very important topic that addresses the outcomes in the critically ill patients who has COVID. I just have a few comments. So I think that one of the questions is the causality or relationship with COVID. Was the death or the outcomes was related to COVID or something else? What I mean is that maybe the patient was admitted to the ICU because he has a major trauma, and he had severe head injury, and he had bleeding and hemorrhagic shock, and he happened to have a COVID positive test. And he died because of the bleeding or the hemorrhagic shock or the severe head injury. So this, I think that's a confounder that it would be interesting if you address this in your study, just to make sure, or at least to minimize, because you cannot completely eliminate it, but to minimize the relationship or association between COVID and the outcomes, and to see if there is the outcomes or the mortality and those clearly or most likely COVID-related deaths are addressed. The other comment is I'm not sure if the Apache score was addressed in the study, or if it was not addressed, I suggest if it's possible to add it, because it would be interesting to see the association between the Apache score in COVID patients and non-COVID patients. Especially in the critically ill patients. So I'm not sure. So concerning the causality and relationship with or association with the cause of death in the COVID patients, if it was addressed or looked into or not. And the second question is the Apache score, if it was added or there is a plan to add it. Thank you very much.
شكرا لك دكتور بدر. Regarding the first point, the outcome and mortality and the causality or the co-founder, yes, I agree with that. It's one of the limitations of the study that we were not able to look at these co-founders, as the systems did not allow at that time for us to see these co-founders. Unfortunately, it's one of the limitations of the study. And about the other one, the other points, yes, we did not apply it. Hopefully, the system was modified and they added more variables, they added more categorizations. Hopefully, we are planning to do another paper with including the other cofactor after the improvement of the system.
دكتور زهير.
طيب شكرا يا فيصل. Very well done. لكن ايكو كومنت حقت زميلي بدر. اول كومنت you know انه WHO define the cause of death to direct, indirect and unrelated. Have you take this in considerations لما حطيتوا الكرايتيريا to look at the mortality rates?
It's similar يعني point mortality صح ممكن تكون direct, indirect or unrelated to COVID or other things, but unfortunately it's one of the big limitations in the study.
I think
we tried, yes.
This need to be looked at. When I would advise you إذا كان في still a chance to look at direct and indirect from the portal of Ministry of Health. تتواصل مع الدكتور أحمد الجديع وتأخذ منه direct cause of death، لأنه إحنا we categorize all death في المملكة العربية السعودية من جميع السيكتورز إلى 3 categories: direct, indirect and unrelated. تأخذ الدايركت from them وتحطهم هم COVID direct cases. لكن لو جاك واحد تروما مثلا زي ما قال دكتور بدر، أو جاك واحد عنده مثلا coincidentally طلع عنده COVID لكنه جايب cancer for example, terminal case, he's a BNR, but it happened that he became positive COVID. Definitely the cause of death is not COVID, it's his disease. For this you need to look into in more details. Number 2, diabetes, it has been shown in a lot of studies, and it's a high predictive value for mortality. أنا ما شفت الدايابيتس عندك only the odds is 1 point something.
diabetes كانت في الريجريشن combined as a couple وكانت significant مع الأذرز، بس isolated كده في ال p value we see it was not significant.
So maybe if you read the literature before when you put the guidelines or for the protocols, you need to have to look at the diabetes and the obesity, because they're very good link between diabetes and obesity to the COVID outcome. And we know for obesity from SARS in 2014 في الجامعة article. لكن بالنسبة للdiabetes new, it has been published in the last few months, and في good correlation between diabetes and bad outcome. Number 3, الSMR يا دكتور، هذا أخذته بعين اعتبار الSMR when you look at mortality in the ICU، لأنه how would you know إنه some hospital they maybe have very soft admission criteria. The patient get admitted to the ICU يكون في contamination samples، بينما other hospital has very strict admission criteria. When the patient get admitted to the hospital يعطيك very high mortality rate in those hospitals. فعشان كده to make sure إنه this would not contaminate your result، تاخذ what Badr mentioned initially is the SMR to look at the Apache 4 score, and you calculate your mortality rate according to the Apache scores. Have you taken this in consideration?
طيب بالنسبة لهذه the system ما أسمعك دكتور.
The SMR.
Yes, the SMR هو we did not يعني count it because in the system it was not giving this data. And I know that collecting data from 2000 more than 200 hospitals, there will be a variability, and one of the limitation in the study. So this is we cannot we couldn't apply it in the study.
طيب ممتاز. اذا كان بالامكان to look into this يمكن في الفيشر ستدي او في هذه الاسم ار. طبعا احنا الان it's a requirement for all Ministry of Health hospitals to record their Apache score upon patient arrival. There is no excuse. So every single patient get admitted to the ICUs, they have their own Apache score being recorded. Maybe we have to look into this more seriously. وهذا حتساعدك كثير. Number two, before you include patient in COVID-related death, you have to take the opinion from the mortality committee اللي بالوزارة إنه this patient فعلا is a direct mortality cause of death. لكن otherwise amazing job being done, Faisal. Thank you very much.
يعطيك العافية. Thank you.
Thank you فيصل، شكرا. well done. طيب دكتور زهير إذا سمحت لي بمداخلة سريعة. أنت ذكرت الدكتور أحمد الرجيع عندنا a lot of residents في البورد السعودي يبغون مع الداتا from الحسن. كيف الطريقة؟ Can you just guide us please إذا تكرمت؟
يعني I don't have a direct access to حصن لكن definitely we could help إذا في شيء بينفع ال populations والبلد في موضوع الريسيرش. احنا we are very advocate وايضا الوزاره very advocate in helping research, especially اذا كان IRB approval من وزاره الصحه after the new guidelines في IRB approval. Definitely they could contact me ولا contact دكتور عبد الله العسيري في الوزاره المساعد ولا IRB في وزاره الصحه to have an access. There's no limitations. Once the IRB is approved, they have full access to it.
ما اعتقد سموه الحصن عبث.
Yes, definitely.
صحيح حسنت ابو عمر حسنت.
طيب ألف شكر للبانلست على the excellent discussion وشكرا دكتور فيصل على البرزنتيشن المميز. Move on to our next presentation. دكتورة غيداء سحيباني. دكتور غيداء موجودة؟
السلام عليكم، صباح الخير. I'll try to share my screen just a moment.
So Dr. Ghaida, she has a case report, DeBakey type 1 aortic dissection presenting as abdominal pain and paraplegia.
Good morning, everyone. Is my screen showing?
تفضلي.
Yeah. Good morning, everyone. This is Ghaida Sahibani, a fourth-year emergency medicine resident from King Saud Medical City. So I'd like to thank the organizing committee for giving me the opportunity to present the research day. Today I'll present a case that I encountered during my rotation in Al Habib Hospital. It's of DeBakey type 1 aortic dissection presenting as paraplegia. So without any further ado, let's start. So we'll brief about aortic dissection. Aortic dissection is uncommon but frequently fatal. 22% of cases undiagnosed prior to death. Physician correctly adopted the diagnosis as few in 15 to 43 of the cases. If left untreated, mortality is as high as 50% in the first 48 hours of onset. So, diagnosis is often delayed or missed. 38.2% of confirmed aortic dissection cases had a missed diagnosis. Regarding the symptoms, usually they can have vague symptoms, but the main presenting symptoms depend on the site of initial internal disruption. So classically, dissection can present with abrupt and severe chest pain that radiate to the area between the scapula and may be accompanied by feeling of impending doom. The other symptoms can present with syncope. They can present with non-specific neurological symptoms. So dissection near carotid artery might present as a classic stroke. 20% of patients with type A dissection display neurological finding, which predicts a poor diagnosis. Interruption of the blood supply to the spinal cord might lead to paraplegia. Further distal dissection may present as a back, flank, or abdominal pain. A proximal dissection to the aortic root may lead to cardiac tamponade and generally fatal. 40% will have no chest pain. So regarding neurological symptoms associated with aortic dissection is often severe, may completely mask the other symptoms, and entails a significant diagnostic challenge. However, diagnosis has many potential difficulties. It may mimic another common conditions, and not all cases can present with typical presentation. So classification, we usually have Stanford and DeBakey classification. DeBakey, the Stanford classification, consider any involvement of the ascending aorta, a type A dissection. Stanford type B dissection are restricted to only descending aorta. DeBakey type 1 is simultaneously involve the ascending arch and descending aorta. Type 2 DeBakey involve only the ascending aorta, and type 3 involve only the descending aorta. So how to diagnose it? Usually history physical examination chest radiograph can suggest the diagnosis. It's only if it's the physician alerts to aortic dissection as the diagnostic possibility in patient with chest pain, back or abdominal pain or neurological symptoms. CT can reliably identify the false lumen, can provide additional details such as anatomy of dissection, location of the dissection flap, extension of the flap into the great vessels. CT protocols should be done with or without IV contrast, depending on the physician practice. Utilization of the CT imaging of patients for presenting with possible dissection varies between 0.6% to 12% of patients with chest, back, or abdominal pain. So back to our case. We had a 77-year-old male known case of hypertension presents to the emergency department. He complained of severe abdominal pain, lower limb pain, and weakness for the last hour. The patient was agitated, refusing to give history, which was challenging. His family was contacted. They reported that he developed abdominal pain 3 hours at home and had high blood pressure reading at that time, which was resolved, and proceed to his current symptoms. They recall no chest pain at all. They mentioned that bilateral lower extremity weakness rapidly progressed, and he had complete loss of sensation, motor control of his lower extremities. No more history could be obtained as the family wasn't aware of any other events. So upon examination of the patient, he was agitated, GCS was 15 out of 15, he looks acutely ill, his heart rate was 52 per minute, his blood pressure was 169/66, his temperature was normal, respiration and autosat was normal. On physical examination, distal pulses were symmetric, patient's abdomen was soft, not tender, mildly distended. There is no probable or palpable pulsatile masses. He was alert and oriented to place, person, time. His power was 5 out of 5 in all muscle groups of both arm, and sensation was intact in upper. He had no movement or any muscle or any power in his legs. Power was 0 out of 5, sensation to light touch, and pinprick was absent from T6 through S5. So pulses couldn't be detected in the lower limb, neither manually or by the Doppler. His ECG showed sinus brady with non-specific ST changes. So bedside echo for the patient was done, showing normal contractility and normal left LV function, minimal pericardial fusion, and mural hematoma at the aortic root. So upon this mentioned information, a CT angio was urgently arranged for the patient. He underwent CT angio. This is the images from the CT angio for the patient. Sorry, I couldn't obtain a better quality. So this is the CT report. It's showing aneurysm with large dissection starting from ascending aorta to include the aortic arch, descending aorta, and abdominal aorta. Also, there's dissection seen the brachiocephalic artery and right subclavian artery and right common carotid artery. It showed almost complete thrombosis of both common iliac arteries and partial thrombosis of both external arteries, and complete thrombosis of both internal iliac arteries. So cardiothoracic was contacted urgently for the patient. They mentioned that the facilities and the OR were prepared in other branch of Al Habib Hospital. We were in Rayyan and they prepared the facilities in Takhasusi Hospital, so patient need an urgent transfer. So we arranged the transfer for the patient. I accompanied the patient in the ambulance. The transfer went smoothly, alhamdulillah. No any concerning events happened. Patient was transferred and went emergency surgical repair and had a good recovery in the ICU. The timeline of AD management, because the time was crucial for this patient, we received him at 6:16 p.m. He underwent the CT angiography. We arranged for transfer by almost 7:20, 7:30. Patient arrived at Takhasusi facilities and was evaluated by cardio surgery and prepared for OR. So challenges that was faced in this case, difficulty in obtaining the history to get to the full clinical picture as the patient not covered of neither the family, atypical presentation, patient had no chest pain, had abdominal pain with paraplegia. Patient family actually has refused to complete the AD management. They insisting to sign DAMA and take the patient to home and bring him if he feels worse. So it's very important to solve this issue by sharing our honest concern about the patient and what's the complications that depending on their decision, and to build a good rapport with the patient's family. So, and the urgency, the other challenge was the urgency to transfer the patient to other facility within the appropriate time frame during the rush hour. So, in conclusion, clinician must be always aware of aortic dissection, even though it may present with fake presentation, and patients may visit the emergency department with atypical complaint or neurological symptoms that may be similar to other neurological symptoms, as in our case has shown. So this concludes my case. To get the full case report and the other references, please feel free to contact me through my email. Thank you, everyone.
شكرا دكتورة غيداء. نسمع من دكتور عبد الله السقا.
السلام عليكم. شكرا دكتورة غيداء. بس my question إنه هذه case report. Did you look for other case report in other, for example, country to make it start to have case series, or just you? Because very interesting and to have presentation like يعني aware. Presentation is not typical. Did you look at, because we'll make it, for example, case series, then they will start to have more higher study for that.
Actually, this was mentioned in the full version of the case report. I looked into case series. I found two cases similar to our case, one in Korea, South Korea, and one in UK. Actually, in UK, the patients only came with paraplegia, no other associated complaint, no abdominal pain or anything like that. So it was isolated paraplegia. And patients only diagnosed as aortic dissection on the 4th day of admission. So they admitted him as a workup for paraplegia. No aortic dissection wasn't in the differential from the AD. And in South Korea also, patient was worked up as ACS, only to find out the patient developed paraplegia during admission, and they were concerned about the aortic dissection.
And you work up first as for aortic dissection, or you put it in your differential diagnosis?
Actually, we put it in our main differential, as patient wasn't given a clear history, abdominal pain and neurological symptoms. It raised the concern for the aortic dissection as two different systems involved and no better explanation for that. And especially that patient vitals were, he was hypertensive and the presenting vitals was suggesting of aortic dissection. So we're concerned about that.
And patient neurologically is fully recovered after operation.
Actually, he's still recovering in the ICU. Need to follow up that to make sure that he recovered the other neurological symptoms.
Okay, thank you so much, Dr. Ahad.
Thank you.
دكتور بدر اليحيى.
السلام عليكم جميعا. Excellent case, good presentation. I think it highlights that if you find someone with chest pain or abdominal pain with neurologic findings, you have to think of dissection, because there is little to, I mean, in the differential, few things can give you the two symptoms together. What's impressive about this case is that you transferred the patient from the time the patient presented until he was in the OR in a different hospital was 55 minutes, which is really, really impressive. I wonder what did you guys do? Like it's sometimes in the same hospital it takes more than an hour. That was a great case actually, and maybe I suggest the same thing with Dr. Abdullah Saga. Maybe you write a literature review on this, a case report and a literature review, to look at the percentage of patients who present with isolated abdominal pain in an extensive dissection like this, because in your CT it looks like the ascending and the descending were involved. Thank you so much. That was a great case.
Thank you. We're planning, inshallah, to do a case series after that and to follow the recovery of the patient.
شكرا دكتورة غيداء.
I have a question, if you allow me.
تفضل دكتور هاني.
Yeah, thank you, Dr. Ghida. Just one comment regarding the same question Dr. Abdullah Saga he raised regarding making a case series. I think we had, in the same month, we had another case, an elderly guy who presented with abdominal pain and hemiplegia. And again, that was in the same month, maybe before you came to our department, Dr. Ghida. Second point regarding your diagnosis was made after the bedside echo, right?
It was highly suspected after the bedside echo, yeah. So we pushed him for the urgent CT, which confirmed.
And do you remember the measurement of the aortic root, which was so dilated?
No, actually, unfortunately, because we were in a hurry to transfer the patient, we couldn't take a proper imaging and the proper measurement for that.
All right. Yeah. So thank you.
دكتور هاني بقول لك البيشنت very agitated, restless, abdomen distended, lots of gases. The ultrasound was really not that helpful, but you know what? From the presentation of abdominal pain and the paraplegia, we really put aortic dissection as number one. Dr. Ghida, great job to deal with the family, and I like the way you deal with them. Alhamdulillah, we rushed to CT scan in a very outstanding time. Alhamdulillah. Thank you, Ghida.
Thank you.
Thank you, Muhammad. I think we had the same challenge. We had that patient was so agitated. He was screaming because of the abdominal pain. And when we did bedside the ultrasound, part of the ultrasound evaluation, but was the bedside echo, and he has dilated aortic root with the pericardial fusion. But that patient, unfortunately, did not make it. He died on table.
الله المستعان. شكرا دكتور غيداء، شكرا دكتور هاني على المداخلة.
دقيقة من فضلك بس.
تفضل.
بس أنا حابب أشكر دكتورة غيداء بصراحة very nice presentation and very nice case. So just I want to say thank you and well done.
You're most welcome. Thank you very much. Thank you for listening.
يعطيك العافية دكتور ماجد أبو عمر. بس بقول لك cardiac surgery in other private hospitals is very challenging. يمكن دكتور سعد العسيري حابب يضيف معلومة الآن. ما شاء الله الدكتور الحبيب في برانش التخصصي cardiac surgery, he told me himself, he did 5 dental procedures for aortic dissection of the ascending, you know. I was really impressed. I think he will release the case series of that one. The way cardiac surgery in a private hospital is growing to help the governmental is very impressive. ممكن دكتور سعد يضيف المعلومة.
بالنسبة للدكتور فعلا he did many cases. تخصصي كمان they have one surgeon also he did actually some cases. I think they have excellent actually number of cases and they are working on publication for such cases. This case was one of the interesting cases. Even the surgeon he was telling actually the emergency team, they did actually a great job of dealing with the case for the full management, the quick communication. So I want to just mention sincerely, thank you so much for the emergency team about what they did. They did actually strong saving life. And again, it was very excellent presentation here about this case.
Excellent. شكرا دكتور سعد. I guess we can move on to our next speaker.
Yes.
Our next speaker is Dr. Abdelmajid Asiri. He's going to present a pattern of chest pain diagnosis in the emergency department. تفضل يا دكتور عبدالمجيد.
السلام عليكم. صوتي واضح؟
نعم تفضل.
اي نعم تفضل.
البرزنتيشن واضح؟
نعم.
حياكم الله. Okay, I'm Abdominal Laceration R2 in National Guard. Today I'm going to present pattern of chest pain diagnosis in emergency department. So in this presentation, I'm going to start with brief introduction about the topic. Then then the aim of the research, in addition to its methodology and finding. Then I will go through the discussion, strength, limitation, and conclusion. Emergency department in Saudi Arabia is considered a gateway in healthcare. According to the Ministry of Health Statistical Yearbook, ED in Saudi Arabia receive more than 21 million visitors per year. So emergency physicians face a spectrum of conditions and presentation, and one of the most common presentation is chest pain. Chest pain is a very serious complaint, and the patient should be evaluated and treated in prompt and accurate manner to prevent mortality and morbidity. Causes of chest pain vary based on its origin, which can be either cardiac and non-cardiac causes. So we're going to start it with the cardiac causes. Cardiac causes of chest pain are often serious and can be life-threatening, and it may include ischemic and non-ischemic condition. For ischemic causes like coronary artery syndrome, unstable angina, myocardial infarction. For non-ischemic causes of cardiac chest pain include myocarditis, dissection aortic aneurysm, mitral valve prolapse. And the risk factor for cardiac disease are hypertension, diabetes, dyslipidemia, obesity, and smoking, family history of cardiac diseases. And the second cause of chest pain is non-cardiac chest pain. It's defined as an angina-like substernal chest pain or tightness of non-cardiac cause. Patients with non-cardiac chest pain can be present sometime with similar symptoms of cardiac disease, like discomfort in substernal area, and the pain could be radiated to the arm, neck, and back. And it could be difficult to distinguish clearly from the cardiac cause of chest pain. For this reason, all non-cardiac chest pain should undergo evaluation by cardiologists to exclude cardiac causes. The causes of non-cardiac chest pain include pulmonary causes like pulmonary embolism, asthma, pneumonia, gastrointestinal causes like esophageal dysmotility, esophageal reflux, esophageal perforation, MSK, and trauma, also infection like herpes zoster, and cocaine-induced chest pain. As shown here, data from various countries shows that from all chest pain presentation, non-cardiac chest pain account for 14 to 33% in different population-based study. However, there's no such data published in Saudi Arabia, and it's believed that such study will help healthcare provider to improve management guideline, patient care, increase index of suspicion, and give an overview of pattern of diagnosing the pattern of chest pain diagnosis in AD setting. Therefore, our aim in this study was to assess the prevalence of cardiac and non-cardiac chest pain in King Abdulaziz Medical City in emergency department presentation. Our specific purpose was to analyze the diagnosis of chest pain in emergency department as it matched with the discharge diagnosis, or it does not, to determine if the patient was given the right plan of care. So this study was approved by KMARC. Our study was a cross-section retrospective study that was conducted in emergency medicine department of King Abdulaziz Medical City in Riyadh, and it was based on 6 months period. In this study, we targeted all adult ER visitor who complained with chest pain from the period January to June 2017. However, we exclude all patients under the age of 14 years old patient coming with traumatic chest pain, and also all non-eligible patients. The data used in this study was obtained from King Abdulaziz Medical City Best Care System, which is a hospital information system that contains the patient medical history through an electronic medical record. We look from the all patient presented to the emergency department to meet our inclusion and exclusion criteria. Demographic data was obtained in addition to final diagnosis by ED consultant. Data were entered in Excel and then converted to SPSS spreadsheet to analyze it. Patient demographic data were described using descriptive statistic, while the mean and standard deviation were calculated for quantitative variables. The sample size was a total of 372 participants, which consists of 194 male and 177 female. Only 355 of them were involved in 30 days follow-up. Cardiac was the prevalent diagnosis on discharge associated with the chest pain with frequency of 62%. Based on the finding, there was an association between the presenting complaints such as chest pain and shortness of breath with ECG result. The association is statistically significant with a p-value of 0.03. Also, there was a significant association between cardiac diagnosis on discharge and ECG result. However, there was no association between MSK and pulmonary and other diagnosis and ECG result. The association is not significant. However, in general, there's an association between diagnosis on discharge and ECG result. And the association was statistically significant. We compared gender to 30 days mortality, but there was no association between them. Also, we compare age versus mortality versus discharge diagnosis and gender, which shows no association, and there was no relationship. Also, in the discussion, no significant difference has been found between mortality in chest pain patients without cardiovascular condition as compared to those in the general population. Patients that were discharged from ED with non-cardiac chest pain had a good prognosis. If the pain not associated with the cardiovascular parameter. The finding of this study reiterate the importance of ECG offers to those patients with whom experience chest pain. ECG is one of the first line diagnosis tool that is vital to evaluate for evaluation of the patient with chest pain who's arrived in ED. The finding reiterates the importance of ECG offered to those patients who experience the chest pain. It concurs with the suggestion of Rashon, who hypothesized that ECG provide an early opportunity to initiate diagnosis workup immediately, since it acts as a guide to start patient the correct treatment, as well as provide necessary referral as is required. According also to Hamilton, availability of ECG result in the emergency department help in minimize any delay in provision of care that considerable reduce of risk of death among patients with the chest pain. However, the result shows that the occurrence of chest pain doesn't appear to influence by either age or gender. So our limitation in this study, weakness is diverse definition of non-cardiac chest pain that limits the practicality of the study finding. That study was limited, is inherited to a single center, also the single center for undertaking the investigation. To conclude, The finding exhibit the mixed information on the long-term morbidity and mortality of non-cardiac chest pain, cardiovascular adverse effects with some showing poor outcome, while others demonstrate a positive outcome. Patients with pre-existing cardiac problem tend to have adverse outcome, as opposite to those with non-cardiac challenge, such as MSK or pulmonary causes. By this, I conclude my presentation. Is there any question?
شكرا يا دكتور عبد المجيد. كن نسلم الميكروفون للدكتور زهير عسيري.
طيب شكرا جزيلا عبد المجيد. well done. ممكن تقول لي what is the definition of the cardiac chest pain؟ لأنه الحقيقة in the last 20 years I've been trying to define it, like I still have difficulty to do so. When you come up with this study, how did you define the cardiac chest pain?
Any chest pain that present with cardiac cause and related to the cardiac origin. I mentioned it.
يعني after يعني any patient who has a chest pain initially in the emergency department and ending up by ACS or
ischemic or non-ischemic. سواء كانت ischemic أو non-ischemic يعني not related to only ischemic causes. أي شيء related للheart, myocarditis, valve prolapse.
Okay, تمام. So what is the definitions of cardiac chest pain? لما أقول والله this is a cardiac, when you say this is a cardiac chest pain, so how would you define cardiac chest pain?
Any chest pain with cardiac origin, so ischemic or non-ischemic.
So this is retrospective, صح؟ يعني after you diagnose, you call it cardiac chest pain. حتى لو جاء patient, حتى even if the patient come in with a pleuritic chest pain.
Exactly. Yes, exactly. Yeah.
Okay. So the main of the study to show how many patients who come to the emergency department with a chest pain ending up by cardiac cause.
Exactly. والباترن وش كان جاي فيه بالضبط؟ يعني هل هو جاي shortness of breath or chest pain؟ وش طلع؟ هل فيها الECG هل فيها changes ولا لا؟ وش طلع الend discharge diagnosis؟
طيب وش المين conclusion؟
انه mainly انه البيشنت اللي جاي بتشست بين وكان عنده ECG finding بالاغلب انه discharge diagnosis related للcardiac origin.
That means those patients
ما لها علاقه بالجندر ولا الايج، يعني الجندر والايج not significant في discharge diagnosis.
I think this is a very important message. If this study reflecting very well, age has nothing to do with the cardiac chest pain or with the diagnosis of ischemia-related diagnosis. I think we are sending very important message, especially for our fellows in an emergency department, because we use to make age as important risk factor to include in patient who come with the chest pain for further diagnosis and investigations. Nowadays, we have a lot of patients especially with hyperlipidemic patients. They come in young age and ending up by MI and the ACS in general. So that's very important. Now, still I have difficulty in calling in emphasizing calling something called cardiac chest pain and non-cardiac chest pain, because as far as I know, the history of chest pain or the chest pain history analysis has no good correlation with the diagnosis. It's exactly what you just mentioned in your study. So people has to take any chest pain seriously, regardless of if it is typical or not typical, cardiac or non-cardiac. Thank you, Abdul Majid.
الله يعافيك.
سميرة.
Assalamu alaikum. Thank you, Abdul Majid, very much for the presentation. I just have two questions. The first question, do you think if you include the non-eligible patients to your study, would it change the conclusion or the results? Because in our institute, we see a lot of non-eligible patients who's coming with significant ECG and they end up diagnosing with ACS related disease. مش كده؟
اي صحيح. المشكله انه عندنا في السيستم انه نحتاج الفولو اب 30 days فولو اب. فالمشكله الeligible patient حتى لو ما كان عنده ischemic cause اذا كان stable بالاغلب حيسووا له يعني discharge for where eligible يعني. فالمشكله ما حتكون الداتا حقتهم واضحه. لانه عندنا مثلا eligible اول ما يدخل ويصير له الادميشن سواء من الكارديولوجي يصير له فولو اب معاهم اسبوع اسبوعين، فهذا نتابع احنا الريزلت حقته. بس المشكله ان eligible بيسوي له مانجمنت مثلا في الاي ار وخلاص they gonna discharge them اذا كانت no ischemic cause يعني.
Yeah, because يعني some of them, especially if it's cardiac, they will be admitted and they can يعني have follow up for more يعني longer durations. طيب the second question بالنسبة للnon cardiac chest pain, it's just a suggestion that if you can just do like a follow up study or something to identify the relation لأنه non cardiac chest pain يعني some of them they're really life threatening causes and they might يعني present with some ECG changes like severe like pulmonary embolism or massive PE. They can have ECG changes especially if they have a strain pattern. مش كده؟
Indeed, yeah.
So it's really interesting to see study يعني about this subject.
Absolutely.
Thank you very much. That's all what I have.
أنا عندي مداخلة صغيرة يا عبد المجيد. قلت الأيم حق استدي أول ما بديت إنه تبغى تعرف نسبة الكاردياك chest pain، بس الكونكلوجن اللي قلتها ما جاوبت السؤال.
اللي قلت إنها 64%. ما كتبتها في الكونكلوجن أنا صحيح ما كتبتها بس 64 حطيتها في الريزلت اللي هي.
فطبيعة الستاديز لازم تكون الأيم راكبة مع الميثود، راكبة مع الريزلتس، والكونكلوجن والدسكشن تجاوب الأيم اللي أنت حطيته.
أي صح، أنا ما حطيتها في الريزلتس، ما حطيتها في صحيح.
شيء ثاني ما هي كبيرة هذه مقارنة بالنسب اللي قلتها. تقول عالميا ما بين 12 إلى 33 وإحنا
النون كاردياك يعني عالميا هو 14 ل 33، عندنا تقريبا 38
النون كاردياك.
اوكي. طيب دكتور ماجد عفوا على المداخله. هو لما قلت نون كاردياك what is the gold standard يعني لما قلت يا عبد المجيد انه those are non cardiac chest pain, what's your gold standard to say they are non cardiac? Are they all ending up by angio وطلع angio clean coronaries؟
لكن based على
discharge
cardiologist discharge.
How accurate cardiologists versus emergentologists to look at cardiac chest pain versus non cardiac chest pain? Have you looked at the study?
هي على اللابز والاشياء اللي طلبوها والمتابعات ما في شيء accurate امانه. ما عندي خلفيه على الاكيرسي.
Okay, so عشان اقول والله this is real cardiac or non cardiac, maybe we have زي ما قال دكتور سمير we have to link this to a gold standard diagnosis, otherwise or mortality. والله after 28 follow up the patient is still alive. That means it's very unlikely to be cardiac chest pain لما جاب القوارب get discharged. But you cannot say this is not cardiac without having either a clear diagnosis or a clear follow up with the patient. That's maybe just echo.
هو الفولو اب بس اللي تبعناه ولا قطعك؟ الفولو اب اللي تبعناه هو 30 day for 30 days يعني only. ولانه طبعا الفولو اب تكون مع الكارديولوجي تقريبا كل اسبوع او اسبوعين. هو يطلع من الاي ار يعني ايذر ادمتد او بعد ما يطلع من الاي ار يجيهم بعد اسبوع او اسبوعين. فكلوز فولو اب يعني.
اوكي تمام.
دكتور ماجد اسمح لي المداخله.
تفضل توفيق.
عبد المجيد for your courage, and I like your courage in asking a very difficult question that nobody can answer until now. طبعا أمل ماتو in the symposium, he killed this question again and again, and there's a huge difference between cardiologist and ER physician regarding the prediction of which patient is a cardiac and which is not. System حتى البريدكشن رول اوت سكورينج سيستم الهارت والاداك والادابتس وغيرهم 10 كلهم they could not answer this question. فاحنا سالنا امل ماتو قلنا له the patient looks sick, he's having chest pain, everything is negative, the patient looks sick, قال take him to the cath lab. If you could not answer your question حتى لو المريض اللي 70 or 80 years old وعندك negative ECG و negative troponin and the patient is really having classical pain or crushing pain, then your assumption and your gut feeling sometimes better than the scoring role. لكن حتى الهارت والادابت والادابت كمان صنفوا البيشنت الى هاي وانترميديت ولو سكور. اللو سكور ما عليهم خلاف، الاوت كم يعني نسبه المورتاليتي في الفيوتشر فيري لو، لكن الانترميديت هذول يعني مثلا واحد 40 years old هايبرتنسيف عنده chest pain و everything else is negative جاي في الانترميديت رينج. هذا controversial بين الكارديولوجي والاي ار physicians. وامل ماتو في السيمبوزيوم يقول في اختلافات كبيره، ولو تسال 10 كارديولوجيست they will give you 10 different answers. you know واحد ياخذ الكاتلاب، واحد يحطه في الشيست بين، واحد مش عارف ايش. فانا اشكر شجاعتك بصراحه، موضوعك جدا جميل ورائع جدا ترى السامبل صغيره بس ما شاء الله انا اليك.
يلا يعطيك يا رب.
ألف شكر يا دكتور عبد المجيد.
يلا يا
We'll move on to our last presentation for the day by Dr. Abdullah al-Sheikh. Dr. Abdullah حيشرح لنا how to gauge the risk of aspiration among patients who will require sedation in the emergency department using gastric ultrasound. تفضل يا دكتور عبد الله.
السلام عليكم، كيف حالكم جميعا؟ مساء الخير. Thank you for giving me the opportunity to present this day. So our topic is accuracy of emergency medicine physicians in performing point-of-care gastric ultrasound. So many patients present to the ER requiring procedural sedation or requiring intubation, and it's good to have an objective measure to risk stratify those patients for aspiration. And pulmonary aspiration is a significant risk factor for morbidity and mortality in the inpatient setting. There are multiple anesthesiology studies regarding point-of-care gastric ultrasound to gauge the risk of aspiration, and it showed high sensitivity and specificity, approaching 100% in detecting full stomach or empty stomach. Our objective in this study is to assess the feasibility and accuracy of emergency physicians in performing and interpreting point-of-care gastric ultrasound. The methodology was prospective, randomized, observer-blinded design. The inclusion criteria was age more than 18 years old, American Society of Anesthesiologists, physical status 1 and 2, BMI 18.5 to 30, ability to understand study protocol, and the exclusion criteria was pregnancy, previous gastric or lower esophageal surgery, non-abnormalities of the upper GI and neurological disorders, and diabetes. So 75 individuals who meet the inclusion criteria were invited to participate, and 25 of them agreed to participate with a response rate of 33%. Study subjects fasted for at least 8 hours for both solids and liquid on the day of the study. They were randomized in a 1-to-1 ratio using a computer-generating list of random numbers to group of 2. The participants were randomized into 2 groups as follows. Subject in group 1, number of participants was 12, remained fasted, and subject in group 2, number of subjects is 13, ingested a solid meal, which is 1 donut and cup of black coffee. Group allocation was concealed in sealed opaque envelope. 10 minutes after ingestion, the gastric ultrasound examination was performed by the participating physicians, consultants, and senior resident after a 30 minutes basic training by a certified sonographer with a previous experience of more than 100 gastric examination and who was blinded to group allocation. So the results here, as we see, consultant R4 and R3, the total true positive was 63, the total false positive was 35, the total true negative is 49, and the total false negative was 28. The total sensitivity was 69%, and the specificity was 58%. So one of the main reasons for, we believe that one of the main reasons for low sensitivity and specificity is the short duration of training, which was 15 to 30 minutes only. No previous experience of gastric ultrasound examination for the examiners. So those two main factors, we believe, participate in this low specificity and sensitivity. Further studies is needed to gauge the risk, to assess the accuracy of emergency physician in doing gastric ultrasound and its utility in predicting gastric aspiration. This concludes my study or our study. Thank you very much. Any question?
شكرا يا دكتور عبد الله. صحيح انك اخر presentation, but we're not letting you off easy. We have two ultrasound gurus who can ask you questions now. أولهم دكتور هاني. تفضل دكتور هاني.
Yeah, thank you, Dr. Abdullah, for this study. It's very interesting. The first question, يعني, do you have a gold standard to look at or to compare with this gastric ultrasound? I know the point of care ultrasound, the gastric ultrasound is not included in the point of care ultrasound. And so you compare it with, what was the gold standard? Who's your gold standard here?
Actually, the participant, part of them ate before the examination and the others did not. So, and based on that, we did the examination.
No, I mean the training, the one who will do the gastric ultrasound. How would you make sure that they do have enough skills for the gastric ultrasound?
For the trainee or the one that did the training?
The one who did the training.
He's a certified sonographer.
Okay.
Who did more than 100 gastric ultrasound examination before. So
okay,
he's the one that did
the training. And they train the resident for this for the gastric ultrasound.
Yes.
How can we make sure about this training? Is it enough? I mean, to be certified for the gastric ultrasound. I mean, they train for, you said, for 30 minutes.
The training was 15 to 30 minutes. Yes.
15 to yeah. I mean, my question regarding this: is it enough to? I mean, to say this is enough time for the training? I mean, to be like certified in the gastric ultrasound.
Yeah. So what we believe is that the main limitation and the main reason for low sensitivity and specificity is the amount of training time.
Okay.
Yeah.
Second point regarding fasting, you compare fasting and non-fasting. And non-fasting, I think they ate donut and they drink coffee. I don't know, is that, I mean, our population, you know, they eat rice and it's not about donut and.
Yeah. But we instructed them to fast before coming to the hospital, and when they came, we offered them the breakfast.
Okay, that was like a very, very light breakfast. I mean,
yes.
تقدر تسميه intercontinental breakfast.
And how would you, I mean, stratify the risk of the aspiration? How would you know that they are at risk of aspiration?
Actually, I think this one will need further study to see if there is correlation between full stomach and increased risk of aspiration or no.
Okay.
But it's like an assumption that if the stomach is full, our conclusion is does emergency physician or are emergency physician able to detect full stomach or empty stomach after 15 minutes of training? And does this correlate with aspiration or no? This needs further study.
Yeah, I mean, the risk of aspiration against the different depends on the, I mean, the age of the patient, comorbids, and the study been done on, I think, healthy individuals, right?
Yes.
Yeah. Yeah, I think this is a limitation in the study.
Yeah. Yes.
Yeah. Yeah. Thank you so much, Abdullah. I know it's very nice, interesting study. Thank you so much.
العفو دكتور هاني يعطيك العافية.
دكتور علي.
العافية دكتور عبد الله.
الله يعافيك.
ما شاء الله you did very well work يعني trying to eliminate كثير من الفاكتورز ربما would affect the results. يعني ما شاء الله randomized و concealed. You try to standardize things very well من ناحية الميلز ومن ناحية الفاستنج. بس يمكن يعني you might reconsider the title. لأنه what is written in the title how to gauge your risk of aspiration. يعني يمكن من أكثر من نقطة. النقطة الأولى أن يعني يعني the aim of your study will assess the accuracy of ultrasound in the gastric contents. يعني doesn't assess the risk of aspiration. القضية الثانية أن
صح
against the recommendation حتى في الACIP يعني في تقريبا 2014 الجايدلاينز أن against الفاستنج for procedure sedation. يعني we cannot translate اللي موجود في الانستيزيا عندنا في الامرجنسي. فهذه يمكن think about it how to rational your study لما تعمل له publication. أنا عارف أن بعض المستشفيات ربما واحدة من البوليسيز ولا for procedure sedation the patient have to be fasting. في ويب سايت دكتور عبد الله لو حاب ربما طلعت عليه يعني since you already started topics اسمه gastric ultrasound. أنا بحطه في أشوف أنا أحطه بعد شوي يمكن أحطه حتى حق جميع المجموعة فيها كل الرفرنسز اللي تحتاجها. يعني هو dedicated for gastric ultrasound والأنستيزيولوجيست هم اللي عملوا نفس الويب سايت هذا مجمعين فيه التكنيك والفايندينجز والليترشر. I'm sure if you communicate with them definitely they will be interested. إضافة أن ساعد كثير to have a full picture about the study. well done. الله يعطيك العافية إن شاء الله.
يعطيك العافية. شكرا جزيلا.
ماجد تفضل.
إذا في باقي أسئلة ثانية.
دكتور ماجد تسمح لي بسؤال؟
تفضل.
ما أدري I may have missed this. What did you look for exactly? Was it the size of the stomach? Was it? I'm not sure. Maybe I missed this.
There's findings which is we look for the stomach and if it is full there will be hyperechoic for the solid and hypoechoic for the liquid and by that we identify either it's full or if it's empty.
Yeah, I mean what is your definition of full? Is it like if there is anything it's full or if there is nothing? And was there a definition for your finding?
Actually, the patient who ate the meal before entering for we consider them to be full. And if the sonographer got that patient that said he has full stomach, then he made the correct choice. This is what he said. Yeah.
بس
thank you.
عبد الله لو حطيت لنا الصور اللي متوقع يشوفونها الناس على اساس يحددوا هو full stomach ولا لا and what was their expectation or the sign that they were looking for على اساس بس تكون واضحه لانه هنا شكله وريناهم صوره بعد 15 دقيقه 30 دقيقه بعدين اطلقناهم على الفولنتيرز يحددون. But if there was a more structured approach تكون مشروحة في الانترودكشن حقت الستدي أو الميثودز أو تكون مشروحة في الميثودز specifically إنه this was the exact signs that we were looking for to determine if this patient patient had a full stomach or not. تكون أوضح للجميع وتكون يعني more to the point. ما عدا ذلك it looks like a really good initiative. راح تعيدونها؟
ليه نعيدها؟
يعني تدربهم مثلا مدة 20 ساعة بعدين تسوي لهم.
والله ممكن أننا نفكر بهذا الموضوع. إيه ممكن أننا نعيدها.
طيب شكرا وألف مبروك على البروجكت وأسأل الله التوفيق للجميع. Thank you all for coming, and with that I'd like to give the microphone back to Dr. Tawfiq to close if he has any closing.
شكرا جزيلا للجميع. شكرا لجميع النجوم التي ضاءت واشرقت سماءنا اليوم. شكرا ولا نقدر يعني ما نقدر نبدا بيمين ونخلي يمين، والف الف شكر لكم. وجودكم شرف معنا، ونسال الله سبحانه وتعالى ان شاء الله نشوفكم في السنوات القادمه. ونعطي الميكروفون لراعي الحفل الدكتور سعد العسيري.
يعطيكم العافيه جميعا. شكرا دكتور توفيق، دكتور ماجد.
عفوا دكتور سعد، بس ترفع الصوت شويه.
الصوت نازل؟
اي
الحين افضل؟
نعم اي نعم تفضل.
طيب الله يعطيك العافيه دكتور توفيق، دكتور ماجد، جميع الزملاء. بصراحه كان very excellent event, very excellent gathering. شفنا الزملاء لنا فتره عنهم. شكرا للزملاء اخواننا الريزيدنتس. بصراحه very excellent topics, very excellent projects, excellent efforts. It was very interesting to see such amazing event among our training program. We feel proud by all these efforts. وبشاكر كل فريق العمل اللي اشتغل على تجهيز هالايفنت، بدءا من الدكتور توفيق وباقي الزملاء، الاستاذه رسميه من الاكاديميك افيرز. وان شاء الله بحول الله حيكون في جاذرينج يوم الاحد للريزيدنت بخصوص توزيع الدروع والشهادات عندنا ان شاء الله في الاداره العامه، ونتشرف ان شاء الله بحضورهم، بحضور الدكتور توفيق وباقي الزملاء، ونتشرف جميعا بوجودهم ان شاء الله ونفخر فيهم دائما. فشكرا مره اخرى، واسعدتونا ان نحتضن هالايفنت وان نقوم خدمتكم لتوفير هالايفنت هذه بين اياديكم، ونسعد دائما ان نكون موجودين باستمرار معكم. شكرا جزيلا لكم.
مدام رسميه انت موجوده معنا؟ مدام رسميه، استاذه رسميه، الاستاذه رسميه يمكن شيء اوف لاين ولا حاجه. طبعا الحمد لله الف شكر في الختام. ونحب نقول انه من مفاجاه من الدكتور سعد العسيري لجميع الباحثين اليوم درع وشهاده لكل من شارك معنا في مهرجان اليوم. تقديرا وشكرا لهم على وجودهم. وان شاء الله باذن الله تعالى نجتمع يوم الاحد القادم، ولولا الكوفيد كان اجتمعنا في المسرح، ولكن ان شاء الله القادم اجمل. شكرا دكتور ماجد وجميع الاعضاء، بشكر واتمنى لكم يوم جميل ان شاء الله. ونختتم حفلنا اليوم، وكل سنه ان شاء الله وانتم طيبين في الامرجنسي ميديسن ريسيرش.
شكرا لكم جميعا.
شكرا. مع السلامه.
مع السلامه جميعا. شكرا.
سعدنا بوجودنا معكم. شكرا لكم.
شكرا دكتور عبد الله. مع السلامه، في امان الله.